Have you ever had one of those days where you just feel completely run down? Or perhaps you've battled a nasty infection and your body felt like it was in a full-scale war?
Yeah, definitely.
Well, in those moments, and actually every single moment, there's this hidden high-stakes biological factory running constantly within you,
Mm.
tirelessly working to replace the billions of blood cells your body uses every single day. And it's not just running, it's like ramping up production, adjusting its output with incredible precision to meet the demands of health or crisis.
It's a profound testament to the body's remarkable self-renewal capacity. Most mature blood cells, you see, they have a finite lifespan, necessitating their continuous replacement.
Right.
This process, which we call hematopoiesis, isn't static. It's an incredibly dynamic system that constantly responds to our basal needs, but can also surge dramatically during periods of increased demand, almost like an internal, precisely calibrated manufacturing plant that can instantly scale up production.
And that's exactly what we're deep diving into today. Welcome to the deep dive, where we're going to pull back the curtain on this fascinating world of hematopoiesis. We'll unravel the intricate mechanisms, explore the powerful molecular signals, and pinpoint the essential building blocks that keep our blood system robust and incredibly responsive.
This deep dive is built on an extensive, authoritative set of sources, truly foundational medical texts. Our mission, as always, is to distill the most critical nuggets of knowledge, helping you not just understand, but truly master this information, empowering you with a profound and comprehensive grasp of how your blood is made and maintained, and, well, what happens when things go awry.
We're going to explore the what, the how, the why, and the cutting-edge therapeutic innovations that have absolutely transformed patient care in this field. I'm genuinely excited to uncover the sheer complexity and elegance of this system that's silently working inside us.
Me too.
It's full of surprising facts and intricate details that will really deepen your appreciation for your own biology. So let's unpack this. Understanding the foundation, hematopoiesis. Let's start at the very beginning with the core concept. The continuous cycle of blood production. Our bodies are constantly turning over blood cells. We're not just talking about a few, we're talking about billions of cells every single day.
Billions. It's staggering.
And this isn't just about replacing what's lost, it's about responding to the needs of the moment.
That's right. The continuous replacement of most mature blood cells is crucial because they do have a finite lifespan. For instance, red blood cells, or erythrocytes, circulate for about 120 days. When there's a need, like in cases of anemia, low red blood cell count, or hypoxemia, which is low oxygen in the blood, erythrocyte production can increase more than 20-fold.
Wow.
That's an astonishing capacity for rapid scale-up.
20-fold. That's like your body going from a small local bakery to a massive industrial plant overnight. And it's not just red blood cells, is it?
No, not at all. Consider leukocytes, or white blood cells. Their production increases dramatically during systemic infections, bolstering the body's immune defense exactly when it's most needed.
Right, like calling in the troops.
Exactly. And then there are platelets, essential for blood clotting. In cases of thrombocytopenia, where platelet counts are low, perhaps due to increased consumption, platelet production can surge an impressive 10 to 20-fold. This constant adjustment to output to maintain critical functions and respond to crises truly showcases the body as a highly responsive internal factory.
So how does this incredible factory know what to make and when? That brings us to the role of stem cells and the specialized environment they live in, the bone marrow microenvironment.
At the very foundation of all blood cell production are hematopoietic stem cells, or HSCs. These are incredibly rare cells found within the bone marrow.
Very rare, you say.
Extremely rare. What makes them so special are two key properties. First, self-renewal, meaning they can make more copies of themselves to maintain their own pool. And second, lineage commitment, which means they have the ability to differentiate and commit to becoming specific types of blood cells.
It's like they're the master blueprints for over 10 distinct blood cell lineages, from red blood cells to various types of white blood cells and platelets. It's an amazing level of pluripotency.
Precisely. In adults, this vital process of hematopoiesis primarily occurs in the marrow cavities of the skull, vertebral bodies, pelvis, and the proximal long bones.
Oh, okay.
And it's not a simple isolated event. It involves intricate interactions among the hematopoietic stem and progenitor cells themselves, alongside the complex cells and macromolecules of the marrow stroma, that's the supportive tissue within the bone marrow.
The stroma, right.
Plus, there's a constant dialogue mediated by soluble and membrane-bound hematopoietic growth factors, which act as crucial signaling molecules.
This sounds incredibly complex. How did we even begin to understand this detailed process of differentiation?
Well, our understanding significantly improved through in vitro culture of marrow cells. These laboratory cultures allowed scientists to observe stem cell differentiation as a series of developmental steps.
In the lab dish, basically.
Yeah, exactly. It starts with what are called mixed blood cell lineage colonies, where multiple types of blood cells are being produced. These then give rise to burst-forming units, or BFUs, which are large and immature and colony-forming units, or CFUs, which are smaller and more mature, each for a specific major blood cell type.
So these are like the specialized assembly lines, BFUs and CFUs.
Exactly. These early progenitors, the BFUs and CFUs, are capable of extensive further proliferation and differentiation, increasing their number by about 30-fold.
30-fold, wow.
And here's where it gets really interesting. It's at this more mature stage of development that the lineage-committed growth factors, like the colony-stimulating factors for monocytes and granulocytes, erythropoietin and thrombopoietin, exert their primary proliferative and differentiative effects. They're the orchestrators, telling these specialized lines to ramp up production of their specific cell type.
So we have this incredible amplification, right? You start with a few stem cells, then their progenitors multiply, and then each of those committed cells generates even more.
Absolutely. The proliferation and maturation of each CFU can ultimately generate over 1,000 mature cells from each committed stem cell, amplifying the product by another 30-fold or more.
Incredible.
This intricate hierarchical system ensures a constant adaptable supply of every blood cell type, from red blood cells carrying oxygen to immune cells fighting pathogens.
That's a powerful biological factory indeed. But even the most sophisticated factory needs raw materials. What are the essential nutrients for blood cell production beyond these amazing growth factors?
You've hit on a critical point. Hematopoiesis absolutely requires an adequate supply of specific minerals and vitamins. Without these basic building blocks, even the perfect stem cells and growth factors can't get the job done.
Makes sense.
The key minerals include iron, cobalt, and copper.
And the vitamins, what are the key ones there?
For vitamins, we're talking about folic acid, vitamin B12, pyridoxine, that's vitamin B6, ascorbic acid, or vitamin C, and riboflavin, vitamin B2.
Okay.
When there are deficiencies in these, they generally result in characteristic anemias. For example, iron deficiency anemia or megaloblastic anemia are direct consequences. Less frequently, but more severely, these deficiencies can lead to a general failure of hematopoiesis across the board.
So if someone is anemic, it's not always just a lack of blood cells, but maybe a lack of the building blocks needed to make them?
Precisely. And that's why therapeutic correction of a specific deficiency state depends critically on an accurate diagnosis of the underlying cause of the anemia. It's not just about knowing what is missing, but also having the knowledge about the correct dose, formulation, and route of administration for that specific mineral or vitamin.
Right.
It underscores the foundational role of nutrition in maintaining a healthy blood system. 2. The orchestrators. Hematopoietic growth factors.
Okay, we've got the raw materials, we understand the incredible stem cells and their intricate factory setup. Now let's talk about the masterminds, the orchestrators. Hematopoietic growth factors. They run a tightly regulated symphony, creating over 400 billion blood cells every single day. That's a mind-boggling scale of production.
It truly is. This scale is achieved through a unique system where several mature cell types are derived from a much smaller number of multipotent progenitors, which in turn develop from an even more limited number of pluripotent hematopoietic stem cells.
So a hierarchy.
Yes, a clear hierarchy. These cells, under the influence of cellular and humoral factors, maintain their own numbers and differentiate to produce that vast and diverse array of mature blood cells.
And these humoral factors are the growth factors, right? What exactly are they?
They are glycoproteins produced by various cells within the bone marrow and other peripheral tissues. What's fascinating here is their potency. They are active at very low concentrations.
Tiny amounts make a big difference.
Huge difference. And while they often affect more than one committed cell lineage, they typically interact synergistically with other factors. This means their combined effect is greater than the sum of their individual effects, and they also stimulate the production of additional growth factors, a process we call networking.
Networking, I like that.
This networking ensures robustness and adaptability in the system.
So it's not just a linear pathway, it's a complex, interconnected web of signals.
Exactly. These growth factors exert their actions at multiple points in cell proliferation, differentiation, and even in the function of mature cells. But here's a crucial point. Despite all this networking and some redundancy for early progenitors, the network for any given cell lineage ultimately depends absolutely on a non-redundant lineage-specific factor.
Ah, okay.
Losing this specific factor, even if other cytokines for earlier progenitors are present, leads to a specific cytopenia, a deficiency in that particular blood cell type.
That makes sense. You can have all the early stage support you want, but if the signal for the final product is gone, you won't get that product. Let's talk about some of these key players. I know we have a whole orchestra of them.
We do. We have erythropoietin, EPO, which primarily stimulates erythroprogenitors for red blood cells. Then there's stem cell factor, SCF, and FLT3 ligand, FL, which act synergistically with many other factors to stimulate pluripotent and committed stem cells. FL also uniquely stimulates dendritic and natural killer cells, important for anti-tumor responses, and SCF also plays a role in mast cells and melanocytes.
And the interleukins, they're a huge family, aren't they? I feel like I hear about new ones all the time.
A vast and diverse family indeed. Interleukins are involved in numerous immunological roles, often acting synergistically with other growth factors. They are crucial for the growth and function of various cell types like B cells, T cells, and natural killer cells. For instance, IL-5 specifically controls eosinophil survival and differentiation, while IL-6 and IL-11 are important for stimulating platelet production.
Then we have the colony-stimulating factors, the CSFs.
Yes. Granulocyte macrophage colony-stimulating factor, GM-CSF, acts synergistically with other factors like SCF and interleukins to stimulate cells that become granulocytes, monocytes, erythrocytes, and megakaryocytes. It also enhances the function of mature neutrophils, monocytes, and eosinophils, improving their migration, phagocytosis, and ability to generate superoxide and perform antibody-dependent cell-mediated toxicity. It even prevents alveolar proteinosis.
Interesting. And granulocyte colony-stimulating factor, G-CSF. That one sounds more specific.
G-CSF is more focused. It primarily stimulates cells that become granulocytes, leading to increased neutrophil production. It enhances their phagocytic and cytotoxic activities, and interestingly, it also reduces inflammation by inhibiting certain cytokines like IL-1, tumor necrosis factor, and interferon gamma. Then there's monocytomacrophage colony-stimulating factor, MCSF, which stimulates monocyte precursors and activates their function.
And finally, for platelets, we have thrombopoietin, TPO.
TPO is key. It stimulates the self-renewal and expansion of hematopoietic stem cells, drives stem cell differentiation into megakaryocyte progenitors, and selectively stimulates megakaryocytopoiesis, which is the process that increases platelet production. Like many others, it also acts synergistically, particularly with IL-6 and IL-11.
It's amazing.
This intricate system truly ensures a constant, adaptable supply of every blood cell type, from oxygen carriers to immune defenders and clotting agents.
It's incredible to think about this symphony playing out inside us all the time. But how did we even get to this level of understanding? What's the history behind discovering these microscopic conductors?
Well, the modern concepts of hematopoietic cell growth and differentiation really took off in the 1950s. Pioneers like Till and McCulloch conducted experiments demonstrating that individual hematopoietic cells could form macroscopic colonies in the spleens of irradiated mice.
Right.
This was monumental because it established the concept of discrete hematopoietic stem cells, suggesting that a single cell could expand into multiple cell lineages. This understanding has since been expanded to human marrow cells, which can now be prospectively identified.
So they actually saw these single cells becoming entire colonies? That's fantastic.
Yes, it was a breakthrough. The foundation for identifying the soluble growth factors themselves was then laid independently by Sachs and Metcalf. They developed clonal in vitro assays for hematopoietic progenitor cells, observing that these colonies only grew in conditioned culture medium from leukocytes or tumor cell lines.
Ah, the conditioned medium clue.
Exactly. This crucial observation led to the isolation of individual growth factors based on their activity in these assays, which, in turn, were instrumental in purifying a hierarchy of progenitor cells committed to various mature blood cells.
That's how they started to pick out the individual signals then. Let's talk about erythropoietin's discovery, the maestro of red blood cells. That name seems to pop up a lot.
It does. The story of erythropoietin goes back to 1906, when Paul Carnot postulated the existence of a circulating growth factor he called hematopoietin. He observed that injecting serum from anemic rabbits into healthy rabbits increased the healthy rabbits' red cell count.
Just based on observation.
Yeah. Fast forward to the 1950s, Reisman, Urslev, and Jacobson rigorously defined the origin and actions of this hormone, now named erythropoietin.
So they moved it from hypothesis to established physiological hormone.
Exactly. Subsequent extensive studies in patients with anemia and polycythemia eventually led to its purification from urine and then to the cloning of its gene. The ability to express erythropoietin at high levels in cell lines completely revolutionized its availability for therapeutic use in humans with anemia.
And what about the white blood cell growth factors? Was that a similar path? GM-CSF, G-CSF?
Very much so. The idea of specific leukocyte growth factors also rose from observing that different condition culture media could induce in vitro growth of colonies containing various combinations of granulocytes and monocytes.
Different recipes, different outcomes.
Pretty much. An activity that stimulated both granulocytes and monocytes was purified from urine lung, leading to the cloning of granulocyte macrophage colony-stimulating factor, or GM-CSF, first from mice in 1984 and then from humans in 1985.
Okay.
Similarly, the discovery of an activity that exclusively stimulated neutrophil production led to the cloning of granulocyte colony-stimulating factor, G-CSF, in 1985. And then the megakaryocyte colony-stimulating factor, thrombopoietin, was purified and cloned in 1998.
So one discovery led to another, building on the same experimental principles. And even lymphocyte growth factors followed this pattern.
Yes, lymphocyte growth factors were identified using assays that measured the capacity of cytokines to promote lymphocyte proliferation in vitro. This led to the identification of IL-7 for all lymphocytes, IL-4 for B cells, and IL-15 for natural killer cells. Recombinant expression of these complementary DNAs then allowed for their production in sufficient quantities for clinical investigations, demonstrating their potential utility.
It's amazing.
This isn't just a list of molecules. It's a century-long journey of scientific discovery, from initial observations to purified proteins, completely transforming how we diagnose and treat blood disorders.
That's a powerful narrative of scientific progress. Now let's talk about some of the real-world applications of this knowledge, starting with erythropoiesis-stimulating agents, or ESAs. These are truly revolutionary.
They are. An erythropoiesis-stimulating agent, or ESA, is a pharmacological substance designed specifically to stimulate red blood cell production. And at the heart of this is erythropoietin itself, which is the most important regulator of the proliferation of committed erythroid progenitors, what we call CF, and their immediate progeny.
And without it, you're in deep trouble.
Exactly. In its absence, severe anemia is invariably present, a condition commonly seen in patients with renal or kidney failure, because the kidney is the primary site of erythropoietin production.
Ah, okay.
Erythropoiesis is controlled by an incredibly finely tuned feedback system, where a sensor in the kidney detects changes in oxygen delivery, which then modulates erythropoietin secretion.
This sounds like a super sophisticated oxygen sensor. How does that work at a molecular level? It sounds complex.
It's quite elegant, actually. The sensor mechanism involves a transcription factor called hypoxia-inducible factor, or HIF. There's a protein made of two parts, HIF1 and HIF1. When oxygen levels are low, HIF boosts the production of multiple hypoxia-inducible genes, including both erythropoietin and vascular endothelial growth factor. Normally, HIF1 is quite unstable, rapidly degraded. But during hypoxia, this degradation is slowed, allowing HIF1 to accumulate, which in turn activates erythropoietin gene expression, leading to a rapid expansion of erythroid progenitors. We've even seen how specific genetic alterations in certain proteins can lead to an oxygen-sensing defect, resulting in continuously high levels of HIF1 and erythropoietin, and consequently polycythemia and excess of red blood cells.
So the kidney is really the command center for red blood cell production.
It is. Erythropoietin is primarily produced in specialized cells of the kidney. Once secreted, it binds to a specific receptor on committed erythroid progenitors in the marrow and is internalized. With anemia or hypoxemia, its synthesis rapidly increases by 100-fold or more, raising serum erythropoietin levels and dramatically stimulating progenitor cell survival, proliferation, and maturation.
But this finely tuned loop can be disrupted, right? It's not foolproof.
Yes, absolutely. It can be disrupted by kidney disease, which is the most common example because that's where EPO is produced, or by marrow damage, or even a deficiency in essential nutrients like iron or specific vitamins.
Okay.
Furthermore, in the presence of infection or inflammatory states, inflammatory cytokines actually suppress EPO secretion, reduce iron delivery, and inhibit progenitor proliferation. This also interferes with iron metabolism through a liver protein called hepcidin.
Hepcidin again.
Yes. Conversely, a loss of hepcidin-producing liver mass or genetic acquired conditions that repress hepcidin can lead to iron overload.
Fascinating how interconnected it all is. From this understanding, we now have real-world erythropoietin preparations. How do these recombinant forms differ? Are they all basically the same?
Preparations of recombinant human erythropoietin like epoetin alpha, epoetin beta, and epoetin zeta differ almost exclusively in their carbohydrate modifications, primarily due to manufacturing differences. They are supplied in single-use vials or syringes for intravenous or subcutaneous administration. While they are cleared from plasma within hours, their effect on marrow progenitors lasts much longer, which is why once-weekly dosing can often be sufficient to achieve an adequate response.
I've also heard of something called darbepoetin. Is that different?
Yes, darbepoetin is an engineered epoetin alpha that displays a longer circulatory half-life, allowing for less frequent dosing while being approved for similar indications.
Ah, convenience factor.
Right. There was also pigeonesitide and erythropoiesis-stimulating peptide, which was approved for CKD anemia. However, it was removed from the market due to post-marketing reports of serious hypersensitivity reactions and anaphylaxis.
Oh, wow.
This highlights the ongoing need for vigilance even after drug approval.
And this is the same kind of stuff that athletes use for blood doping, right? To, cheat.
Unfortunately, yes. Recombinant human erythropoietin, such as epoetin alpha, is nearly identical to the endogenous hormone. While the carbohydrate pattern differs slightly from the native protein, it doesn't significantly alter the drug's kinetics or potency. However, modern assays are sophisticated enough to detect these subtle differences, allowing them to identify athletes who use the recombinant product for blood doping.
Gotcha.
This misuse is strongly discouraged and has tragically been implicated in the deaths of several athletes.
That's a serious risk for performance gain. Beyond that, what are the therapeutic uses, monitoring protocols, and potential adverse effects of ESAs, the clinical side?
Recombinant erythropoietin therapy, when combined with adequate iron intake, can be highly effective in many anemias, especially those associated with a poor erythropoietic response. Its applications are broad, including anemias linked to surgery, AIDS, cancer chemotherapy, prematurity, and certain chronic inflammatory conditions. Darbepoetin alpha, for instance, is approved for anemia associated with chronic kidney disease.
So it's effective. What about monitoring and potential issues? Iron is key, you said.
Yes, during ESA therapy, patients can develop either absolute iron deficiency or a functional iron deficiency. Functional iron deficiency means they have normal stored iron levels, but the body can't mobilize that iron quickly enough to support the increased red blood cell production.
Right, the demand outstrips supply, basically.
Exactly. Therefore, supplemental iron therapy is recommended for patients with specific low iron markers. We monitor the hematocrit, or hemoglobin, regularly. It's critical to note that if hemoglobin increases too rapidly, the dose should be decreased due to the association of a rapid rise in hemoglobin with adverse cardiovascular events.
Okay, that's important.
Remember, hemoglobin changes lag behind dosage adjustments by 2 to 6 weeks due to the time required for new red blood cell production.
What are the more serious adverse effects, especially given the black box warnings I've heard about? Those always sound serious.
They are serious. The use of ESAs is indeed associated with an increased risk of thrombosis, or blood clots. The risk of thrombotic events is notably higher if the goal of ESA therapy is to reach normal hemoglobin levels compared to a lower target.
So aiming too high is risky.
Yes. Beyond that, ESAs have been linked to increased rates of cancer recurrence and decreased on-study survival in patients receiving the drugs for cancer-induced or chemotherapy-induced anemia.
That sounds incredibly concerning, especially for cancer patients.
It is, which is why the FDA issued black box warnings. These highlight the increased risk of death, serious adverse cardiovascular reactions, and stroke when ESAs are administered to target hemoglobin concentrations near normal physiological levels. In fact, the FDA specifically stated that ESAs should not be used to increase hemoglobin concentrations above 11 grams per deciliter.
11. Got it. What are some of the other common side effects?
The most common side effect is aggravation of hypertension, occurring in 20% to 30% of patients, often linked to a rapid rise in hematocrit levels. Hypertensive encephalopathy and seizures have even occurred in chronic renal failure, patients treated with epoetin alpha.
Wow.
For this reason, ESAs are not used in patients with pre-existing uncontrolled hypertension, and patients may require initiation or increases in antihypertensive therapy. Other reported side effects include headache, rapid heart rate, swelling, shortness of breath, nausea, vomiting, diarrhea, injection site stinging, and flu-like symptoms like joint and muscle pain.
Let's break down some specific clinical uses of ESAs, starting with anemia of chronic renal failure. That seems like a prime candidate.
Patients with anemia secondary to chronic kidney disease are considered ideal candidates for epoetin alpha therapy. This is because their condition represents a true hormone deficiency state, as their kidneys are no longer producing sufficient erythropoietin. ESA use in CKD patients significantly reduces the need for red cell transfusions. The dosing is individualized, aiming for the lowest effective dose to reduce transfusion needs. While subcutaneous administration is generally preferred because it requires less drug due to slower absorption, the intravenous route is typically used for patients already on hemodialysis. The goal is a gradual rise in hemoglobin to less than 11 grams per deciliter, as higher levels are not recommended due to increased risks.
And if they don't respond, if the drug just doesn't seem to work?
Resistance to therapy is common, often due to an inflammatory illness or iron deficiency, so close monitoring of their general health and iron status is essential. Less common causes include occult blood loss, folic acid deficiency, carnitine deficiency, inadequate dialysis, aluminum toxicity, or certain bone disorders. If a patient doesn't respond over a 12-week escalation period, ESA therapy is typically discontinued, as further dose increases may raise risks without improving benefits.
What about anemia in patients with AIDS? Has that changed over time?
Epoetin alfa was initially approved for HIV-infected patients with anemia caused by zidovudine therapy. Excellent responses were seen. However, a more recent analysis from 2011 did not support its routine use.
Why the change?
This shift reflects the effectiveness of modern HIV therapy, which has changed the underlying causes of anemia in HIV-infected individuals. So, ESAs are not commonly used in this population now unless they have indications similar to non-HIV patients, such as anemia associated with renal failure.
And anemia associated with hematological malignancy, like myelodysplastic syndrome or MDS. What's the thinking there?
Guidelines do support the use of recombinant erythropoietin in patients with low-grade myelodysplastic syndrome. In this setting, neutropenia often dictates the use of G-CSF, which frequently augments the erythroid response to erythropoietin.
Interesting synergy there.
Yes. Responding patients typically see their response last for 2 to 3 years. A baseline serum erythropoietin level can help predict response. Most patients with levels greater than 500 IU per liter are unlikely to respond. For those who do respond, there's an improvement in their anemia and their overall sense of well-being.
I recall the warning about cancer concerns. How do ESAs apply to anemia in cancer patients undergoing chemotherapy? This seems like a tricky area.
It is. Epoetin alpha therapy can reduce transfusion requirements and anemia-related symptoms in cancer patients undergoing chemotherapy. Previous guidelines used to recommend its use when hemoglobin fell below 10 grams per deciliter. However, case reports suggested a direct effect of both epoetin alpha and darbepoetin alpha in stimulating tumor cells.
Stimulating the tumor itself, that's bad.
Very concerning. A meta-analysis of a large number of patients in clinical trials even estimated about a 10% higher risk of death compared to cancer patients not treated with these agents.
That's a huge finding. How did guidelines change after that?
Based on those results, new guidelines were issued. They now state that ESAs may be offered to patients with symptomatic chemotherapy-associated anemia and hemoglobin values of less than 10 grams per deciliter, only if they cannot tolerate or refuse red blood cell transfusions, and if their cancer treatment is considered palliative.
Okay, so much more restricted use.
Much more. The crucial point here is that the goal of ESA treatment should not be to normalize hemoglobin values, but to mitigate the symptoms of anemia. And, importantly, iron supplementation may still be necessary to improve the response.
What about using ESAs in perioperative patients, those around the time of surgery, to maybe reduce transfusion needs?
Epoetin alpha has been used perioperatively to treat anemia, specifically to raise hematocrit to 30% to 36%, and to reduce the need for allogeneic red blood cell transfusions in patients undergoing surgery with anticipated moderate or large blood loss, such as elective orthopedic and cardiac procedures.
Makes sense.
This approach is particularly useful for patients who cannot receive transfusions. For example, many Jehovah's Witnesses find recombinant epoetin alpha acceptable.
Are there any other uses or misuses for epoetin alpha? We touched on doping.
Right. Epoetin alpha has been evaluated for treating anemia of prematurity, where impaired erythropoietin production is central to the problem. However, its efficacy in decreasing the number of blood donors an infant is exposed to appears limited. A more effective approach is to limit the amount of blood drawn from the infant and to use satellite packs that divide 1 unit of donated blood into smaller aliquots for successive use.
Practical solution.
There was also one retrospective study that associated epoetin alpha administration in premature infants with an increased incidence of retinopathy of prematurity. And of course, as we mentioned earlier, The misuse by competitive athletes for blood doping to boost hemoglobin levels for performance is strongly discouraged due to its link to several athlete deaths.
So ESAs are powerful, but with great power comes great responsibility in their clinical application. Let's shift gears to an even newer approach that focuses on a different mechanism: the sequestration of transforming growth factor beta superfamily ligands. That's a mouthful. What is it and how does it work?
This is a truly fascinating and more targeted approach. Transforming growth factor beta, or TGF superfamily ligands, are soluble growth factors that play a crucial role in regulating hematopoiesis. The signaling pathways used by these TGF family ligand receptor complexes actually inhibit hematopoietic stem cell proliferation.
So they're like a brake on blood cell production, keep things in check.
Exactly. Under normal conditions, erythroid progenitor cells, the cells that will become red blood cells, naturally produce certain ligands, like activins and growth differentiation factors, or GDFs. These ligands normally inhibit terminal erythroid differentiation by inducing programmed cell death and cell cycle arrest in erythroblasts. This creates a tightly regulated negative feedback loop, preventing overproduction.
So that's normal. What happens in diseases like thalassemia or MDS?
In disorders of ineffective erythropoiesis, such as thalassemia or myelodysplastic syndrome, there's a continuous increase in this inhibitory signaling. This means that brake on red cell maturation is continuously applied too strongly, leading to a persistent anemia.
And this is where a new drug, luspatercept, comes in. How does it work? Is it blocking that signal?
Luspatercept is a recombinant fusion protein. It acts as a ligand trap. It specifically binds and sequesters select TGF family ligands, including GDF8, GDF11, and activin B. Importantly, it does not bind to other similar TGF molecules, giving it a very targeted effect.
So by trapping these inhibitory ligands, it takes the foot off the brake, allows maturation to proceed.
Precisely. This pattern of ligand trapping decreases the inhibitory signaling. By doing so, it effectively disinhibits and promotes erythroblast differentiation and erythroid maturation with fewer non-hematological effects. It's a highly specific way to promote red blood cell production by addressing an underlying signaling imbalance rather than just broadly stimulating cell division.
That's a fantastic example of precision medicine. What are its clinical applications and considerations? Where is it used?
Luspatercept is indicated for adult patients with beta thalassemia who require regular red cell transfusions. In a phase 3 clinical trial, approximately 20% of patients achieved at least a 33% reduction in their transfusion burden, compared to only 4.5% in the placebo group.
That's a big difference.
Huge. Even more strikingly, 11% achieved transfusion independence. At the end of a 2-year period, about 70% of patients initially on luspatercept were still receiving treatment and experiencing a reduction in their transfusion burden.
That's a significant impact for patients who often need frequent transfusions. How is it dosed? Is it complicated?
The starting dose is 1 milligram per kilogram, administered subcutaneously every 3 weeks by a healthcare professional. Dosing is often delayed if hemoglobin levels reach 11.5 grams per deciliter or greater, unless it's due to a recent transfusion. If a patient doesn't achieve a reduction in transfusion burden after at least 6 weeks, the dose can be increased to 1.25 milligrams per kilogram, which is the maximum dose.
And it's also approved for myelodysplastic syndromes, or MDS, right, under specific circumstances.
Yes, the FDA has approved luspatercept for adult patients with very low to intermediate risk MDS with ring sideroblasts, or specific MDS myeloproliferative neoplasms who are anemic despite ESA therapy and require 2 or more red blood cell units over an 8-week period.
And the results there?
In a phase 3 trial for this group, the primary response rate, defined as transfusion independence for 8 weeks or longer, was 38%. Approximately 70% of patients experience an increase in hemoglobin of at least 1.5 grams per deciliter. The recommended starting dose for MDS patients is also 1 milligram per kilogram subcutaneously every 3 weeks, and it can be increased up to 1.75 milligrams per kilogram if they aren't achieving red blood cell transfusion independence.
What are the adverse effects for luspatercept? Any major concerns?
In the beta thalassemia trials, thromboembolic events occurred in 3.6% of patients treated with luspatercept, compared to 0.9% in the placebo group. All these events were in patients who had undergone splenectomy and had other risk factors for blood clots, so it's recommended to consider clot prevention in patients at increased risk and to monitor all patients for signs and symptoms of blood clots.
Okay, so a risk, but maybe specific to certain patient groups.
Potentially. Other adverse events for beta thalassemia patients include transient bone pain, joint pain, dizziness, hypertension, and high uric acid. For MDS patients, the most common side effects reported are mild fatigue, diarrhea, asthenia, nausea, dizziness, and back pain. Importantly, blood clots have not been associated with luspatercept in MDS patients, and to date, its use has not been linked to an increased risk of progression to acute myeloid leukemia, though long-term follow-up is ongoing.
Luspatercept truly represents a paradigm shift, targeting the underlying signaling pathways that lead to ineffective erythropoiesis rather than just stimulating production. This precision is a huge step forward in treating challenging blood disorders. Now let's talk about myeloid growth factors, which are all about boosting our body's defenses, the white cells.
Myeloid growth factors are another class of glycoproteins that stimulate the proliferation and differentiation of one or more myeloid cell types. While recombinant forms of several have been produced, only G-CSF and GM-CSF have found truly significant clinical applications. These factors are naturally produced by a variety of cells, including fibroblasts, endothelial cells, macrophages, and T cells, illustrating their intricate interactions in the body.
And they work at extremely low concentrations, right? Like the other growth factors we discussed.
Yes, they are incredibly potent. They activate an important intracellular communication route called the JAK-STAT signal transduction pathway.
Let's delve into granulocyte macrophage colony stimulating factor, or GM-CSF, also known as sargramostim. What does it do?
Sargramostim is a recombinant human GM-CSF. Its primary therapeutic effect is the stimulation of myelopoiesis, meaning the formation of myeloid cells, which include granulocytes and monocytes. But its actions are broader. It acts synergistically with other growth factors like erythropoietin and stimulates a variety of colony-forming units to increase cell production across these lineages.
So it's not just about stimulating production, but also enhancing function, making the existing cells work better.
Absolutely. GM-CSF also enhances the migration, phagocytosis, and ability to generate superoxide and perform antibody-dependent cell-mediated toxicity of neutrophils, monocytes, and eosinophils. Its initial clinical application was in patients undergoing autologous marrow transplantation, where it significantly shortened the duration of neutropenia, a low neutrophil count, thereby reducing transplant morbidity without affecting long-term survival or the risk of cancer relapse.
And what about in allogeneic transplantation, where the marrow comes from a donor? Is it useful there too?
Its role there is less clear. Its effect on neutrophil recovery is less pronounced in patients receiving prophylaxis for graft versus host disease. However, it may improve survival in transplant patients who experience early graft failure.
Okay.
GM-CSF has also been used to mobilize certain progenitor cells for peripheral blood stem cell, or PBSC, collection for transplantation after high-dose chemotherapy. Furthermore, it shortens neutropenia and reduces complications in patients receiving intensive cancer chemotherapy and stimulates myelopoiesis in some patients with cyclic neutropenia, myelodysplasia, aplastic anemia, or AIDS-associated neutropenia.
How is it administered and what are its side effects? Are they significant?
Sargramostim is administered by subcutaneous injection or slow intravenous infusion. With the initiation of therapy, there's a transient initial decrease in white blood cell counts, followed by a dose-dependent increase over 7 to 10 days, returning to baseline within 2 to 10 days after discontinuation.
Interesting dip first.
Yeah, it's typical. Lower doses primarily yield a neutrophil response, while larger doses can cause an increase in monocytes and eosinophils. Frequent blood counts are essential to avoid an excessive rise in granulocyte counts.
And the side effects?
Side effects are more pronounced with higher doses and include bone pain, general malaise, flu-like symptoms, fever, diarrhea, shortness of breath, and rash. An acute reaction to the first dose can occur in sensitive patients characterized by flushing, low blood pressure, nausea, vomiting, and shortness of breath, often with a fall in arterial oxygen saturation due to white blood cell sequestration in the pulmonary circulation.
Sequestration, like they get stuck somewhere.
Temporarily, yeah, in the lungs. With prolonged administration, a few patients may develop a capillary leak syndrome, leading to swelling and fluid accumulation in the lungs and around the heart. Other serious side effects include transient heart arrhythmias and elevations of kidney and liver markers.
That brings us to granulocyte colony stimulating factor, or G-CSF, with agents like filgrastim and its relatives. This one has really transformed stem cell transplantation, you mentioned.
It truly has. Recombinant human G-CSF, known as filgrastim, primarily stimulates cells that become granulocytes, leading to increased neutrophil production. It also enhances the phagocytic and cytotoxic activities of neutrophils and reduces inflammation by inhibiting certain immune signaling molecules.
And how did it transform transplantation? What was the key insight?
The pivotal observation was that G-CSF mobilizes primitive hematopoietic cells, including hematopoietic stem cells, from the marrow into the peripheral blood.
Ah, it pulls them out into the bloodstream.
Exactly. This means you can collect these stem cells directly from the blood rather than needing a bone marrow harvest. This has virtually transformed the practice of stem cell transplantation, so much so that more than 90% of all such procedures today use G-CSF mobilized peripheral blood cells as the donor stem cell product.
That's a huge shift from what it used to be. What are the advantages of that? Seems much easier for the donor.
Definitely easier for the donor, typically. Peripheral blood stem cell grafts also offer a higher cell dose and somewhat more committed progenitor cells than traditional marrow grafts, leading to faster engraftment and faster immunological reconstitution.
Faster recovery, that's huge.
Beyond transplantation, G-CSF-induced mobilization of stem cells into the circulation also has the potential to enhance the repair of other damaged organs, where these peripheral blood stem cells might play a role. Still early days for some of that, but promising.
What forms of G-CSF are available? Are there variations?
Several forms are available, including filgrastim and two longer-acting pegylated forms. Pegfilgrastim and lipigfilgrastim, which have a prolonged duration of effect and reduced kidney clearance.
Pegylated, meaning attached to something to make it last longer?
Exactly, polyethylene glycol. There's also tibofilgrastim and biosimilar filgrastim senzalase, which are pharmacokinetically, safely, and efficaciously similar to filgrastim, so more options becoming available.
And its clinical applications. Where is G-CSF used most?
Filgrastim is highly effective in treating severe neutropenia after autologous hematopoietic stem cell transplantation and high-dose cancer chemotherapy. It shortens the period of severe neutropenia and reduces complications from bacterial and fungal infections.
So preventing infections during chemo.
Critically important.
Yeah.
G-CSF is also effective in treating severe congenital neutropenias and can improve neutrophil counts in some patients with myelodysplasia or marrow damage, such as aplastic anemia or tumor infiltration of the marrow. It can even partially or completely reverse the neutropenia experienced by AIDS patients receiving zidovudine. And of course, it's routinely used to promote progenitor cell release, reducing the number of collections needed for PBSC transplantation.
How is it administered and what should patients expect? Is it daily, like GM-CSF?
Filgrastim is administered by subcutaneous injection or intravenous infusion. A typical starting dose for a patient receiving chemotherapy is 5 micrograms per kilogram per day. The drug's half-life is 3.5 hours. Daily administration for 14 to 21 days or more may be needed after intensive chemotherapy.
And the longer-acting one, pegfilgrastim.
For pegfilgrastim, its prolonged half-life allows for single-dose administration rather than daily, typically given 24 hours after chemotherapy and at least 14 days prior to the next planned chemotherapy dose to avoid impacting the rapidly dividing myeloid cells. Frequent blood cell counts are essential to determine effectiveness and guide dosage adjustments.
What are the adverse reactions for G-CSF? Bone pain seems common with these.
Adverse reactions to filgrastim include mild to moderate bone pain, particularly with high doses over a protracted period, and local skin reactions following subcutaneous injection. A rare but serious side effect is a skin inflammation called cutaneous necrotizing vasculitis. It's contraindicated in patients with a history of hypersensitivity to Escherichia coli-produced proteins, and critically, in patients with sickle cell anemia, as it has been known to precipitate severe crises and even death.
Oh, that's a very important contraindication.
Absolutely critical.
Wow.
Mild to moderate enlargement of the spleen has also been observed in patients on long-term therapy.
I remember hearing about concerns regarding malignancy in healthy stem cell donors who received G-CSF. Can you speak to that? Was that resolved?
That's an important point. In the mid-2000s, some papers suggested that healthy stem cell donors receiving G-CSF for mobilization displayed marrow cell changes that raised concerns for the future development of cancer. Previous studies had also shown an increase in myeloid leukemia in breast cancer patients receiving G-CSF for low white blood cell counts.
Right, that sounds worrying.
It did. However, and this is crucial, careful, and extensive long-term follow-up, has failed to reveal any meaningful increase in myeloid leukemia in normal stem cell donors who were administered G-CSF. This demonstrates the importance of long-term data in understanding drug safety.
That's reassuring for donors. When comparing GM-CSF and G-CSF, which one is typically preferred in clinical practice? Is there a clear winner?
There are limited comparative data from randomized controlled trials and insufficient data to recommend one CSF over the others for the primary prevention of febrile neutropenia. However, in practice, most institutions tend to use G-CSF rather than GM-CSF. Guidelines from the American Society of Clinical Oncology support the use of all G-CSF preparations, including biosimilars.
So while both stimulate immune cells, G-CSF's specific focus on neutrophils and its profound impact on stem cell mobilization have made it a cornerstone in modern oncology and transplantation. Let's move to the platelet promoters. Thrombopoietic growth factors. What are our options there?
Right. Let's start with interleukin-11, or IL-11, known therapeutically as oprovecan. IL-11 is a cytokine with broad physiological roles. It stimulates hematopoiesis, promotes intestinal epithelial cell growth, and even bone remodeling, while inhibiting fat cell formation. More specifically for our topic, IL-11 enhances megakaryocyte maturation in vitro.
And megakaryocytes are the cells that produce platelets, correct? The big ones.
Yes, that's correct. Recombinant human IL-11, oprovecan, leads to a thrombopoietic response, meaning it boosts platelet production within 5 to 9 days when administered daily to normal subjects. The drug is approved for use in patients undergoing chemotherapy for non-myeloid malignancies who have severe thrombocytopenia, that is, a platelet count below 20 A109 per liter. It's administered daily until the platelet count returns to more than 100 AP109 per liter.
What's the dosing, and what are the major complications? Any big red flags?
The typical dose is 25 to 50 micrograms per kilogram per day subcutaneously. The major complications of therapy are fluid retention and associated cardiac symptoms, such as rapid heart rate, palpitations, swelling, and shortness of breath. This is a significant concern, especially in elderly patients, and often requires concomitant therapy with diuretics to manage the fluid.
Fluid retention, okay. Now let's talk about thrombopoietin, or TPO itself. This is the primary regulator of platelet production, but its journey to a therapeutic agent had some significant bumps, didn't it?
Indeed. Thrombopoietin is a glycoprotein produced by the liver, marrow, stromal cells, and other organs. It is unequivocally the primary regulator of platelet production. Early in its development, 2 forms of recombinant TPO were tested clinically.
And what happened? Why aren't we using recombinant TPO directly?
While their use in patients with low platelet counts was found to be safe, a crucial setback occurred. The use of one recombinant TPO in a clinical trial of normal platelet donors intended to boost the quantity of donated platelets led to donor thrombocytopenia in several subjects.
The opposite effect.
Exactly. This was due to the immunogenicity of the agent. Their bodies developed antibodies to the recombinant TPO. This experience led to both early recombinant TPO agents being abandoned for clinical use.
That's a crucial lesson in drug development. Even if a substance mimics a natural hormone, the body's immune response to recombinant forms can be a critical hurdle. But that setback led to newer solutions, right? The thrombopoietin receptor agonists, or TRAs, these are different.
Exactly. The experience with recombinant TPO spurred the development of small molecular mimics of recombinant TPO, termed thrombopoietin receptor agonists, or TPO-RAs, also known as TPO mimetics. These agents work by stimulating the production of megakaryocytes and platelets in the marrow through activating the TPO receptor, but they are structurally different enough to avoid that immune response.
Ah, cool.
They are now FDA approved for use in patients with immune thrombocytopenia, or ITP, and several are also approved for patients with liver disease who are scheduled to undergo surgery.
Which are the key TRA agents? What are the names we might hear?
One key agent is roneplostim. It contains a small peptide that binds with high affinity to the TPO receptor. It's proven safe and efficacious in ITP. It's administered weekly by subcutaneous injection, with the dose titrated until the platelet count increases above 50 A9 per liter. It's important to note it's not intended to completely normalize platelet count, but rather to reduce bleeding risk.
Just get it into a safer range. And then there's eltrombopag. Is that similar?
Eltrombopag is a small organic non-peptide TRA, which can be administered orally. So that's a big difference. It's a pill.
Oral, yeah.
It's approved for severe aplastic anemia, often as a first-line therapy in combination with immune suppression, as well as for chronic hepatitis C, virus-associated thrombocytopenia, and ITP. Again, it's not intended to completely normalize platelet counts. For patients with chronic HCV, it may actually increase the risk of liver problems.
Are there other oral options besides eltrombopag?
Yes. Avatrombopag is another oral non-peptide TRA that is more potent than eltrombopag and has fewer stringent dietary restrictions or need for liver function test monitoring. It's approved for chronic ITP in patients with insufficient response to prior treatment, and also for adults with chronic liver disease and thrombocytopenia who are scheduled for surgery.
Okay.
For pre-procedural use, avatrombopag is started 10 to 13 days prior to the scheduled procedure and dosed for 5 consecutive days, with surgery typically occurring 5 to 8 days after the last dose.
And another one, lusutrombopag. Similar purpose.
Luspatercept is also an oral non-peptide TRA, approved to increase platelet counts in patients with thrombocytopenia due to liver disease who are scheduled for elective surgery. It's dosed at 3 milligrams once daily for 7 days, beginning 8 to 14 days prior to the scheduled procedure, with surgery conducted 2 to 8 days after the last dose.
So a growing arsenal of these agents, especially for the pre-surgery setting. What about risks and monitoring for TRAs? Is thrombosis still a concern?
One of the risks associated with TRAs is thrombosis, or blood clots. L-thrombopoietic, for example, has been linked to a risk of portal vein thrombosis in patients with advanced liver disease, though many of these cases also had high platelet counts and other potential causes of thrombosis. Interestingly, the risk of thrombosis was not noted in trials of pre-procedural avatrombopag or lucitrombopag, perhaps due to the limited duration of those specific trials. And for patients with chronic ITP, the risk of thrombosis was not found to be increased with TRA as compared to placebo, so it's context-dependent.
Are there any other long-term concerns like effects on the bone marrow?
Patients on TRAs have been noted to develop myelofibrosis, which is a scarring of the bone marrow. However, this is generally reversible and has not been associated with the development of deficiencies in other blood cell types.
Okay, reversible is good.
Given the short lifespan of platelets, especially in patients with ITP, platelet counts can drop precipitously after abrupt discontinuation of a TRA, sometimes even below their prior baseline. Patients need to be closely monitored for large fluctuations in platelet counts if treatment is stopped or paused.
Right, no sudden stops. This shows how medical science adapts from initial setbacks, like the immunogenicity of the original TPO, to create new, safer, and more effective treatments like TRAs, offering significant hope for patients with challenging platelet disorders. 3. The essential building blocks. Minerals and vitamins for hematopoiesis. We've talked about the cellular machinery, the stem cells, and the chemical signals, the growth factors. Now let's go back to basics, to the absolute foundational building blocks. The minerals and vitamins that are essential for hematopoiesis. We'll start with iron, truly the cornerstone of red blood cells. It comes up so often.
Iron is paramount. In our environment, iron largely exists in forms that are difficult for the human body to absorb unless solubilized by acid or chelating agents. While many mammals can acquire iron fairly easily, humans appear to be an exception. Despite often consuming more than enough elemental iron in our diets, its bioavailability can be quite limited.
So even if we eat enough, our bodies might not be able to get it out of the food efficiently. That's a key point.
Exactly. This is why iron deficiency is the most common nutritional cause of anemia in humans. It can result from inadequate dietary intake, malabsorption, blood loss, or an increased requirement, such as during pregnancy. When severe, it leads to a characteristic microcytic hypochromic anemia, meaning the red blood cells are small and pale.
But iron isn't just about hemoglobin, is it? It does other things too.
No, it's far more fundamental. Beyond hemoglobin, iron is an essential component of myoglobin, various heme enzymes like cytochromes, and other metalloфлавоprotein enzymes. This means iron deficiency can affect muscle metabolism independently of oxygen delivery due to reduced activity of iron-dependent mitochondrial enzymes. It's also been associated with behavioral and learning problems in children and possibly impaired heat production.
So feeling tired isn't the only symptom, especially for kids. Where does the body store iron? Where does it keep its reserves?
Our body's iron stores are divided into essential iron-containing compounds and excess storage iron. Hemoglobin dominates the essential fraction. For storage, we primarily use ferritin, a protein-iron complex that can hold thousands of iron atoms. Ferritin aggregates are referred to as hemosiderin. The two predominant sites of iron storage are the reticuloendothelial system and the hepatocytes in the liver.
How does the iron move around in the body? Is there a specific carrier?
Internal exchange of iron is primarily accomplished by transferrin, a plasma protein that delivers iron to cells via specific receptors. Cells dynamically regulate their iron uptake and storage in response to the iron supply, controlled by intricate iron-regulating proteins. About 80% of the iron circulating in our plasma goes to the bone marrow to be packaged into new red blood cells. When these red blood cells are old, they're recycled by the reticuloendothelial system.
How much iron do we typically lose? Are we constantly losing a lot?
The human body conserves its iron stores to a remarkable degree. Only about 10% of the total iron is lost per year by normal men, which is about 1 milligram per day.
That's not much.
Not much at all. However, additional losses are significant for women due to menstruation, and even greater during pregnancy and lactation. Other causes of iron loss include blood donation, the use of anti-inflammatory drugs that cause gastric bleeding, and various GI diseases with associated bleeding.
So absorption is key since we conserve so much. How is iron absorbed and what controls it? Is there a master switch?
You're right, absorption is of primary importance in determining the body's iron content. After food digestion, iron is absorbed in the small intestine through a series of specific transporters. The master regulator of iron absorption is a liver protein called hepcidin. Hepcidin effectively limits the amount of iron released into the blood by controlling iron transporters.
So hepcidin dysregulation is behind some iron overload conditions, like hemochromatosis.
Yes, exactly. Conditions that enhance hepcidin levels, such as inflammation, can decrease gut iron absorption, leading to less iron available for red blood cells. Conversely, when hepcidin levels are low, as seen in conditions like hemochromatosis, iron overload occurs due to excessive iron absorption. Hereditary hemochromatosis can be due to genetic defects in hepcidin itself or in proteins that regulate its expression. Acquired hemochromatosis can also result from excessive iron intake, or from conditions like hepatitis C or chronic alcoholism that impair hepcidin production.
It's amazing to think that something as common as iron deficiency was once such a mystery. How long have we really understood this complex metabolism? What were the key breakthroughs?
The modern understanding of iron metabolism really began in 1937 with the work of McCants and Widdowson on iron absorption and excretion. In 1947, Laurel described transferrin, the key plasma iron transport protein. In the next decade, Huff and Associates initiated studies of internal iron metabolism. A huge leap came in 1994 when Federer and colleagues identified the HFE gene, which is mutated in hereditary hemochromatosis.
The genetic link.
Right. And more recently, in 2001, Gans and colleagues discovered hepcidin, which we now know is the master regulator of iron homeostasis and plays a critical role in the anemia of chronic disease. So understanding iron has been a continuous scientific quest, from early observations to identifying specific genes and master regulatory molecules.
Let's discuss dietary iron. What are the requirements and where do we get it? How much do we actually need?
Adult men must absorb about 1 milligram of iron per day. Menstruating women require slightly more, around 1.4 milligrams daily. However, in the last 2 trimesters of pregnancy, requirements surge to about 5 to 6 milligrams per day, and infants have similar high requirements due to their rapid growth. So the need for iron can vary dramatically throughout life.
When we think about food, is the total iron content the most important thing or something else, like bioavailability?
The bioavailability of iron in food is of greater nutritional significance. Heme iron, found in meat, poultry, and fish, is far more available and is absorbed independently of the overall diet composition.
Okay, heme iron from meat is easier to absorb.
Much easier. Non-heme iron, found in plant-based foods, is generally less absorbed, largely due to inhibitory dietary components. However, vitamin C and meat can both facilitate the absorption of non-heme iron. High iron foods include organ meats, brewer's yeast, egg yolks, and certain dried beans and fruits. Foods low in iron include milk and most non-green vegetables. Even cooking in iron pots can add to intake. Overall, it's crucial to consider both the amount of iron ingested and its bioavailability.
Now that we understand dietary iron, let's talk about iron deficiency itself. How prevalent is it? Is it still a major issue?
Iron deficiency anemia in the U.S. affects about 1% to 4% of the population, depending on economic status. In developing countries, the prevalence is much higher, with up to 20% to 40% of infants and pregnant women affected.
Wow, still very high globally.
Yes. Fortunately, better iron balance has resulted from practices like fortifying flour, using iron-fortified infant formulas, and prescribing medicinal iron supplements during pregnancy.
What are the main causes? Again, just to reiterate, blood loss seems like a big one.
The anemia results from dietary intake that's inadequate to meet normal requirements, or from blood loss or interference with iron absorption. More severe iron deficiency is usually the result of blood loss. And as we discussed earlier, treatment with erythropoietin can also induce a functional iron deficiency, where the body simply can't mobilize stored iron fast enough.
What are the impacts of iron deficiency, especially on children? You mentioned learning problems.
Iron deficiency in infants and young children can lead to behavioral disturbances and can impair their development, which critically may not be fully reversible. It also increases the risk of lead toxicity in children and increases the absorption of other heavy metals. So it's not just about feeling tired, it has profound, long-lasting effects.
Who are the groups at highest risk? Who should be most concerned?
Premature and low birth weight infants are at greatest risk, especially if they are not breastfed or do not receive iron-fortified formula. After the age of 2 to 3 years, the requirement for iron actually declines until adolescence, when rapid growth combined with irregular dietary habits again increases the risk of iron deficiency. Adolescent girls are particularly at high risk, as the dietary iron intake of most girls is insufficient to meet their requirements.
So understanding who is at risk is vital for prevention. Let's move to treating iron deficiency, starting with oral iron therapy. What are the general therapeutic principles? How do we approach it?
The response to iron therapy is influenced by several factors: the severity of the anemia, the patient's ability to tolerate and absorb oral iron, and any complicating illnesses, such as chronic blood loss or malabsorption defects. Therapeutic effectiveness is best measured by the resulting increase in the rate of red cell production.
How is the effectiveness measured clinically? What do doctors look for?
Clinically, we track the reticulocyte response. That's the count of young red blood cells, and the rise in hemoglobin or hematocrit. You won't see an increase in the reticulocyte count for at least 4 to 7 days after starting therapy, and a measurable increase in hemoglobin takes even longer.
Patience is needed.
Yes. A decision regarding the effectiveness of treatment shouldn't be made for 4 weeks after starting. An increase of 2 grams per deciliter or more in hemoglobin by that time is considered a positive response, assuming no other clinical changes or transfusions.
What if the response is inadequate? If it doesn't work after 4 weeks?
If the response is inadequate, the diagnosis must be reconsidered. A full lab evaluation should be done, and we look for reasons like poor patient compliance, concurrent inflammatory disease, or continued bleeding. If no other explanation is found, then evaluating the patient's ability to absorb oral iron is considered. There's no justification for simply continuing oral iron therapy beyond 3 to 4 weeks if a favorable response hasn't occurred.
How long does treatment typically last, especially to build stores? Is it just until the anemia is gone?
The duration of treatment is governed by the rate of hemoglobin recovery and the desire to replenish iron stores. Red cell mass is usually reconstituted within 1 to 2 months. However, creating iron stores requires many months of oral iron administration. The rate of absorption decreases rapidly after anemia recovery, and after 3 to 4 months of treatment, stores may only increase slowly.
So it takes time to refill the tank.
Exactly. The strategy for continued therapy depends on the estimated future iron balance. Patients with an inadequate diet may require continued low doses, while if bleeding has stopped, no further therapy is needed after hemoglobin normalizes. For continued bleeding, long-term high-dose therapy is indicated.
Is prophylactic oral iron recommended for everyone? Just in case.
No, prophylactic use of oral iron should be reserved for patients at high risk, including pregnant women, women with excessive menstrual blood loss, and infants. It can also be valuable for rapidly growing infants consuming substandard diets and adults with a recognized cause of chronic blood loss. However, except for infants, where fortified formulas are routine, the general use of over-the-counter multivitamin and mineral mixtures to prevent iron deficiency should be discouraged.
Which oral formulations are best, and are there differences in efficacy? Does the type of iron salt matter?
Orally administered ferrous sulfate is often the treatment of choice for iron deficiency due to its cost effectiveness, especially in resource-poor settings. The small intestine regulates absorption, limiting iron entry with increasing doses, providing a natural ceiling on how much iron can be supplied orally. Ferrous salts are absorbed about 3 times, as well as ferric salts. Variations of the particular ferrous salt, like sulfate, fumarate, gluconate, have relatively little effect on bioavailability. The effective dose is based on the elemental iron content.
What about the form of the tablet itself, like coatings or delayed release?
The amount of iron in the tablet is important, and it's essential that the tablet coating dissolves rapidly in the stomach. Delayed release preparations are available, but absorption from such preparations varies, and they are generally not preferred.
Not preferred, okay.
Ascorbic acid, or vitamin C, can increase the absorption of medicinal iron, but this increased uptake is associated with an increase in the incidence of side effects. Preparations that combine iron with other compounds like vitamin B12, folate, or cobalt are not recommended because the patient's response to the combination cannot be easily interpreted.
What are the common side effects of oral iron, and how is it typically dosed? I know people complain about stomach issues.
Common side effects of oral iron preparations include heartburn, nausea, upper gastric discomfort, and either diarrhea or constipation. A good policy is to initiate therapy at a small dosage and then gradually increase it to the desired dose to improve tolerance. Iron overload, or hemochromatosis, is a hazard only for individuals with underlying disorders that augment iron absorption.
And for dosing, I've heard there's been a shift in recommendations, not multiple times a day anymore.
That's a great point. Traditionally, adults with iron deficiency were treated with 150 to 200 milligrams of elemental iron in up to 3 divided doses. However, newer data challenge this. It shows that dosing more than once a day may actually be counterproductive by decreasing iron absorption due to increased hepcidin levels, and it also increases the risk of side effects.
Ah, that hepcidin again.
Yes. Therefore, the current recommendation often leads towards once daily administration of ferrous sulfate 325 milligrams on an empty stomach. This dosage typically maximizes absorption while maintaining high tolerance.
So less frequent dosing, paradoxically, can be more effective. Interesting.
For children, half the average adult dose can be given. Small children and infants can tolerate relatively large doses of iron. For preventing iron deficiency in pregnant women, 15 to 30 milligrams of iron per day are usually adequate. It's also important to note that iron bioavailability is reduced when taken with food or concurrent antacids. For a rapid response or to counteract continued bleeding, higher doses may be administered.
What about iron poisoning? It sounds like it can be very dangerous, especially for kids.
It can be. Large amounts of ferrous salts are toxic, and while fatalities are rare in adults, most deaths occur in children, particularly between the ages of 12 and 24 months. As little as 1 to 2 grams of iron may cause death. All iron preparations absolutely should be kept in child-proof bottles.
Absolutely.
Symptoms of severe poisoning can appear within 30 minutes after ingestion or be delayed for several hours. They include abdominal pain, diarrhea, or vomiting. Of particular concern are pallor, drowsiness, hyperventilation due to acidosis, and cardiovascular collapse.
So it's a very serious medical emergency. What's the treatment?
Indeed. If death doesn't occur within 6 hours, there might be a transient period of apparent recovery, followed by death in 12 to 24 hours. The corrosive injury to the stomach can also result in scarring. In evaluating a child suspected of ingesting iron, a color test for iron in the gastric contents and determination of the iron concentration in plasma can be performed. If the plasma level is low, the child is not in immediate danger. However, vomiting should be induced if iron is still in the stomach, and an X-ray should be taken, as iron tablets are radiopaque. When the plasma concentration of iron is high, a chelating agent called deferoxamine should be administered.
A chelator to bind the iron.
Right. The speed of diagnosis and therapy is paramount. With early treatment, the mortality from iron poisoning can be reduced dramatically. For chronic iron overload, oral iron chelators like deferoprone and deferocyrox are FDA approved for patients with thalassemia.
Oral iron is the first line, but sometimes it's not enough or not tolerated. That's when parenteral iron therapy or IV iron comes in. When is that used?
Yes. Parenteral iron administration can be a very effective alternative to oral iron. Previously, parenteral iron formulations carried a higher risk of severe allergic reactions. However, newer 5E iron formulations have a much lower risk, so IV iron may be considered sooner in the treatment paradigm for iron-deficient patients.
Safer now.
Common indications include iron malabsorption, such as in sprue or short bowel syndrome, oral iron intolerance, as a routine supplement to total parenteral nutrition, and in patients receiving erythropoietic. Parenteral iron allows for rapid repletion of iron stores within 1 or 2 sessions, which would take months to achieve by the oral route.
What are some of the available IV iron formulations? Are there many different types?
There are several in the U.S. Pharmoxytol is a carbohydrate-coated iron nanoparticle approved for iron deficiency anemia in CKD patients. We also have iron dextrin, an older colloidal solution. While low molecular weight versions reduced its toxicity, it still carries a higher risk of immediate anaphylactic reactions, so a test dose is always required, and patients must be carefully monitored. The intramuscular route is generally not preferred due to local reactions.
Okay, so IV preferred for dextrin. What else?
Sodium ferrogluconate is another IV iron preparation with a lower risk of serious allergic reactions than iron dextrin. Iron sucrose is also generally better tolerated and causes fewer adverse events than iron dextrin, and is FDA approved for treating iron deficiency in CKD patients. Ferrocarboxymaltose allows for a larger dose of iron to be administered in a single, relatively short infusion. It's FDA approved for iron deficiency anemia. And the newest one, iron isomaltoside, or ferric derismaltose, is designed to have lower immunogenicity and can provide full correction of an iron deficit with a single infusion.
Lots of options now.
These newer formulations generally aim for safer and more convenient administration compared to older options, making IV iron a more accessible and effective choice.
This comprehensive section on iron highlights its absolute necessity, the complexities of its absorption and regulation, the widespread impact of its deficiency, and the nuanced, evolving approaches to its treatment. Now let's move on to some of the supporting cast. Copper, pyridoxine, and riboflavin. Maybe less famous, but still important.
Indeed, these micronutrients might be lesser known in common discussion of blood health, but they are absolutely vital. Let's start with copper, which is truly an unsung cofactor. Like iron, copper has important roles in the body's chemistry, but can also be toxic if not properly managed. Cells have virtually no free copper. It's always bound to proteins for storage and delivery. The liver is the primary organ for copper storage, distribution, and excretion. Genetic mutations that interfere with copper transport are responsible for severe disorders like Menkes syndrome or Wilson disease.
So if copper is so important, is copper deficiency common? Do we need to worry about it?
Copper deficiency is extremely rare. The amount present in food is usually more than adequate. Even when blood copper levels are low due to certain conditions, direct effects of copper deficiency are often not seen. When anemia due to copper deficiency does occur, it has been described in individuals who have undergone intestinal bypass surgery, those receiving long-term intravenous nutrition, malnourished infants, and surprisingly, in patients ingesting excessive amounts of zinc.
Excessive zinc can cause copper deficiency. How does copper deficiency cause anemia?
It interferes with the absorption of iron and its release from storage cells. In humans, the prominent findings have been a low white blood cell count, particularly granulocytopenia and anemia. If a low plasma copper concentration is found with these symptoms, a therapeutic trial with copper is appropriate. So, while rare, copper deficiency highlights the intricate interplay of micronutrients in hematopoiesis, demonstrating that issues in one can cascade into others, like iron metabolism.
Next, let's talk about pyridoxine, or vitamin B6, which is crucial for certain sideroblastic anemias. What are those exactly?
Sideroblastic anemias, whether hereditary or acquired, are characterized by impaired hemoglobin synthesis. Patients with these conditions accumulate iron in the mitochondria of their red blood cell precursor cells, forming what are called ringed sideroblasts. The hereditary form is a genetic trait that affects an enzyme called delta-aminolevulinate synthase.
And is pyridoxine always the answer for sideroblastic anemia? Does it fix all types?
Not always. Oral therapy with pyridoxine is of proven benefit in correcting sideroblastic anemias associated with the antituberculosis drugs, isoniazid and pyrazinamide, which act as vitamin B6 antagonists.
Drug-induced deficiency.
Exactly. A daily dose can completely correct this defect without interfering with the tuberculosis treatment, and routine supplementation is often recommended. However, it's important to note that if pyridoxine is given to counteract sideroblastic abnormalities associated with levodopa, it can decrease levodopa's effectiveness in controlling Parkinson's disease. Furthermore, pyridoxine therapy does not correct sideroblastic abnormalities caused by other toxins like lead.
So it's a very specific solution for a specific problem, not a general fix.
Exactly. Patients with idiopathic acquired sideroblastic anemia generally fail to respond to oral pyridoxine. For those individuals who do appear to have a pyridoxine-responsive anemia, prolonged therapy with large doses is required. This shows how drug-induced deficiencies can mimic genetic disorders, and how targeted vitamin therapy can be incredibly effective for specific conditions, even reversing severe anemia.
Finally, what about riboflavin, vitamin B2? Does it play a major role in blood production?
The spontaneous appearance of red cell aplasia, a failure of red blood cell production due to riboflavin deficiency in humans, is undoubtedly rare if it occurs at all. Riboflavin deficiency has been described in combination with infection and protein deficiency, both of which are capable of producing a type of anemia where cell production is low.
So maybe an indirect effect.
Possibly. While not a primary player in many anemias, it seems reasonable to include riboflavin in the nutritional management of patients with gross, generalized malnutrition. Its mention highlights the breadth of nutritional factors that can indirectly impact blood health, especially in vulnerable populations.
This brings us to the dynamic duo. Vitamin B12 and folic acid, critical for megaloblastic anemias. These two are so intertwined, aren't they? Their stories seem linked.
They are absolutely central, and their roles are intricately intertwined at the cellular level. Both vitamin B12 and folic acid are dietary essentials. A deficiency of either vitamin directly impairs DNA synthesis in any cell undergoing chromosomal replication and division. Because tissues with the greatest rate of cell turnover, like the hematopoietic system, show the most dramatic changes, they are especially sensitive to deficiencies of these vitamins.
So blood cells, gut lining, anything that divides rapidly, what are their specific roles in the cell? How do they interact?
Intracellular vitamin B12 is maintained as two active forms, methylcobalamin and deoxydenosocobalamin. Methylcobalamin supports a crucial reaction that converts homocysteine to methionine, which is essential for normal folate metabolism and consequently for DNA synthesis.
Okay, B12 helps folate do its job there.
Right. The other form, deoxydenosocobalamin, is a cofactor for a mitochondrial enzyme important in carbohydrate and lipid metabolism, and this reaction has no direct relationship to folate.
So the pathways diverge there. How does folate metabolism specifically work? What's its main function in this context?
The principal folate supplied to cells is methyltetrahydrofolate. Its methyl group transfer to cobalamin is essential for the adequate supply of other folate forms. These other forms are critical for accepting 1-carbon units, eventually forming 5010-methylentetrahydrofolate. This last derivative then donates a methylene group for the synthesis of DTMP, a critical step in DNA synthesis.
This is truly a complex dance, and if one partner is missing, the whole thing can go wrong. Is this why both deficiencies lead to megaloblastic anemia, that specific type of large red blood cell?
Exactly. A deficiency of either vitamin B12 or folate interferes with DNA synthesis. When vitamin B12 is deficient, the body essentially traps available folate in a form that cannot be used for DNA production. This is known as the methylfolate trap.
The methylfolate trap.
Got it. This shared mechanism provides a common biochemical basis for the development of megaloblastic anemia with a deficiency of either vitamin B12 or folic acid.
And what about the neurological lesions we hear about with B12 deficiency? That seems unique to B12.
The mechanisms responsible for the neurological lesions of vitamin B12 deficiency are less well understood. Damage to the myelin sheath is the most obvious lesion in this neuropathy. Importantly, this neurological damage can occur even independently of the changes in the blood system.
Even without anemia?
Yes. Therefore, vitamin B12 deficiency must be considered in elderly patients presenting with dementia or psychiatric disorders, even if they are not anemic. This is not just about two vitamins, it's about a biochemical dance, where one misstep by B12 can trap folate, leading to a common and severe consequence: megaloblastic anemia, and for B12, potential neurological damage.
It's incredible how many breakthroughs were required to map out these pathways. It's a rich history of discovery, isn't it?
It really is a dramatic story spanning almost 200 years, including 2 Nobel Prize-winning discoveries. It began in 1824 with Coombe and Addison, who first described what is now known as Addisonian pernicious anemia. In 1860, Austin Flint first described a severe gastric atrophy and called attention to its possible relationship to the anemia. After Whipple's observation in 1925 that liver is a source of a potent hematopoietic substance, Minot and Murphy conducted their Nobel Prize-winning experiments demonstrating the effectiveness of feeding liver to reverse pernicious anemia.
Eating liver cured it. Amazing early finding.
Yes. Soon after, Castle defined the need for both intrinsic factor, a substance secreted by the stomach, and an extrinsic factor, the vitamin-like material in crude liver extracts.
So a missing factor from the stomach and a missing factor from food, both needed.
Exactly. It took nearly 20 more years before Ricks and co-workers and Smith and Parker independently isolated and crystallized vitamin B12. And the remarkable Dorothy Crowfoot Hodgkin later received the 1964 Nobel Prize in Chemistry for determining the crystal structure of vitamin B12 by X-ray techniques.
That's a huge achievement. What about folic acid's discovery? Was that separate?
While attempts were being made to purify the extrinsic factor, a researcher named Wills and her associates described a macrocytic anemia in women in India that responded to a factor present in crude liver extracts, but not in the purified fractions known to be effective in pernicious anemia.
Something different was going on.
Right. This factor, initially called Wills factor, is now known to be folic acid. The term folic acid itself was coined by Mitchell and co-workers in 1941 after its isolation from leafy vegetables.
So neither B12 nor folic acid were discovered in their active forms. They needed conversion in the body.
Correct. We know that neither vitamin B12 nor folic acid, as purified from foodstuffs, are the active coenzymes in humans. They must be modified in vivo to be effective. Despite our extensive knowledge of the intracellular metabolic pathways where these vitamins function as cofactors, many questions remain, such as the precise relationship of vitamin B12 deficiency to the neurological abnormalities that occur in megaloblastic anemia. This history truly illustrates the power of observation, perseverance, and interdisciplinary collaboration in medical breakthroughs.
Let's delve deeper into vitamin B12 and its impact on human health. Where do we get it from?
Humans depend entirely on external sources of vitamin B12, as it's primarily synthesized by microorganisms found in soil or the intestinal lumen of animals. Our daily nutritional requirement, typically 3 to 5 micrograms, must generally be obtained from animal byproducts in the diet. Strict vegetarians rarely develop vitamin B12 deficiency if they fortify their diets. Therapeutically, we use stable forms like cyanocobalamin or hydroxycobalamin.
And just to recap its metabolic functions for our listeners, why is it so vital?
The active coenzymes, methylcobalamin and 5-deoxydenosylcobalamin, are essential for cell growth and replication. Methylcobalamin is required for the conversion of homocysteine to methionine, which affects DNA synthesis. Deoxydenosylcobalamin is involved in carbohydrate and lipid metabolism.
How is B12 absorbed, distributed, metabolized, and excreted? You said deficiency is often about absorption, not diet.
This is where B12 deficiency often stems from, not necessarily diet. Dietary vitamin B12 is released from food in the stomach and then binds to gastric intrinsic factor. This complex then travels to the small intestine where it's actively transported into the bloodstream. In adults, vitamin B12 deficiency rarely results from diet alone. Instead, it usually reflects a defect in this complex absorption sequence.
Like what kind of defects?
This can be due to antibodies against stomach cells or intrinsic factor, pancreatic disorders, bacterial overgrowth in the intestine, or damage to the small intestine from disease or surgery. Also, congenital absence of transcobalamin II, the transport protein.
And once it's absorbed, where does it go?
Once absorbed, vitamin B12 binds to a plasma protein called transcobalamin II for transport to tissues. Most of the body's vitamin B12 stores, about 1 to 10 milligrams, are in the liver, stored as the active coenzyme. The body also recycles some B12 through the enterohepatic circulation, where it's secreted into bile and then reabsorbed. Interference with this reabsorption by intestinal disease can progressively deplete liver stores.
So how is vitamin B12 deficiency diagnosed, and what are its clinical impacts? How do we know someone is deficient?
The plasma concentration of vitamin B12 is the best routine measure. Deficiency should be suspected if the concentration falls below 150 picomoles per liter. However, blood levels can be misleading if other transport proteins are elevated. In such cases, serum methylmalonate is a more sensitive and useful marker for identifying metabolic deficiency.
Methylmalonate. Okay, and the impact.
Anemia and
Vitamin B12 deficiency is recognized clinically by its impact on both the hematopoietic and nervous systems. The blood system is highly sensitive due to its rapid cell turnover. An inadequate supply of vitamin B12 leads to highly abnormal DNA replication, causing maturing cells to be unable to complete their divisions, resulting in ineffective hematopoiesis. Severe deficiency affects all blood cell lines, leading to a general reduction in red cells, white cells, and platelets.
And the nervous system damage can be really severe, even permanent.
Yes, vitamin B12 deficiency can cause irreversible damage to the nervous system. This neurological damage can occur even independently of the changes in the blood system. Therefore, vitamin B12 deficiency must be considered in elderly patients presenting with dementia or psychiatric disorders, even if they are not anemic.
What are the confirmatory tests for diagnosis, beyond the blood levels?
For severe megaloblastic anemia, a therapeutic trial using very small doses of the vitamin can help confirm the diagnosis by tracking blood cell counts and markers like serum iron to define the characteristic recovery. The Schilling test, which measures vitamin B12 absorption, can also be used to delineate the mechanism of the disease by differentiating between intrinsic factor deficiency and primary small intestine disease, although the Schilling test isn't as commonly used now.
Let's discuss navigating vitamin B12 deficiency and its therapy. It sounds like there are some common misconceptions about it, like it being a general tonic.
Yes. Vitamin B12 has an undeserved reputation as a general health tonic. Many multivitamin preparations are marketed, some supplemented with intrinsic factor, but these preparations are generally not reliable for patients with intrinsic factor deficiency. The choice of administration, injection, or oral always depends on the underlying cause of the deficiency. Oral administration cannot be relied on for effective therapy in patients with marked vitamin B12 deficiency and abnormal blood counts or neurological deficits.
So injection is usually the treatment of choice, especially if it's serious.
Yes, the treatment of choice for vitamin B12 deficiency is cyanocobalamin, administered by intramuscular IM or subcutaneous SC injection, never intravenously. Doses typically range from 1 to 1,000 micrograms. Doses greater than 100 micrograms are cleared rapidly from plasma into the urine, meaning administering larger amounts of vitamin B12 won't result in greater retention.
What are the general principles of B12 therapy? What are the key things to keep in mind?
First, vitamin B12 should be given prophylactically only when there's a reasonable probability that a deficiency exists or will exist. This includes strict vegetarians, patients who have had a gastrectomy, or those with certain small intestine diseases that cause predictable malabsorption.
Okay.
Second, The relative ease of treatment shouldn't prevent a full investigation of the deficiency's cause, especially when megaloblastic anemia or an unexplained neuropsychiatric disorder is present. Third, therapy should always be as specific as possible. While many multivitamin preparations are available, using shotgun vitamin therapy for B12 deficiency can be dangerous.
Why dangerous?
Because providing sufficient folic acid can lead to a blood count recovery that masks continued vitamin B12 deficiency, allowing neurological damage to develop or progress irreversibly.
That's a critical warning. Don't mask the B12 problem with folate. What about acutely ill patients? How do you handle them?
While a classical therapeutic trial with small amounts of vitamin B12 can help confirm the diagnosis, acutely ill elderly patients may not be able to tolerate the delay in correcting severe anemia. Such patients require supplemental blood transfusions and immediate therapy with both folic acid and vitamin B12 to ensure rapid recovery.
Both, okay.
For the next 1 to 2 weeks, the patient should receive daily intramuscular injections of cyanocobalamin, along with a daily oral supplement of folic acid. If there's severe anemia and tissue oxygen deprivation, transfusions of packed red blood cells may be needed.
What does the monitoring look like after treatment begins? How do you know it's working?
The first objective blood change is the disappearance of the abnormal blood cell morphology in the bone marrow. Blood iron levels fall dramatically within the first 48 hours as it's rapidly used for hemoglobin. Increased new red blood cell production begins around the second or third day and peaks 3 to 5 days later. It's crucial to monitor blood counts. If the response isn't as expected, the patient should be reevaluated for complicating factors like iron deficiency, infection, or kidney disease.
And the neurological improvement, does that recover fully?
The degree and rate of improvement in neurological signs and symptoms depend on their severity and duration. Those present for only a few months usually disappear relatively rapidly. However, when a defect has been present for many months or years, full return to normal function may never occur.
So long-term therapy is crucial for B12, usually lifelong.
Absolutely. Once begun, vitamin B12 therapy must be maintained for life. This fact must be impressed upon the patient and their family, and a system must be established to guarantee continued monthly injections of cyanocobalamin. Intramuscular injection of 100 micrograms of cyanocobalamin every 4 weeks is usually sufficient.
Okay.
Patients with severe neurological symptoms may be treated with larger doses for several months immediately after diagnosis, with the hope of encouraging faster and more complete recovery. It's important to monitor vitamin B12 concentrations in plasma and obtain peripheral blood counts every 3 to 6 months to confirm the adequacy of therapy, as refractoriness can develop at any time. Intranasal preparations are also available for maintenance if there's no nervous system involvement.
This detailed breakdown underscores the critical need for accurate diagnosis and tailored, often lifelong treatment, especially distinguishing B12 from folate deficiencies due to the risk of irreversible neurological damage. That distinction is key. Finally, let's turn our attention to folic acid, the other half of this duo. What are its biochemical roles?
Tauryl glutamic acid, or TGLU, is the common pharmaceutical form of folic acid. It's not the principal folate found in food, nor is it the active coenzyme for intracellular metabolism. After absorption, it's rapidly converted to tetrahydrofolic acid, which then acts as an acceptor of various 1-carbon units, crucial for many metabolic processes.
Like the conversion of homocysteine to methionine, which we mentioned involves B12 too.
Exactly. This reaction requires methyl tetrahydrofolate as a methyl donor and uses vitamin B12 as a cofactor, underscoring their synergy. Another key role is in DNA synthesis. A specific folate derivative donates a methylene group for the synthesis of DTMP, which is an extremely important reaction in DNA synthesis. It's also involved in other metabolic pathways like histidine and purine synthesis.
What are the daily requirements for folate, and where do we get it from food? Is cooking an issue?
Many food sources are rich in folates, especially fresh green vegetables, liver, yeast, and some fruits. However, lengthy cooking can destroy up to 90% of the folate content.
90%? Wow.
Yeah, it's sensitive. For normal adults, the recommended daily intake is 400 micrograms. Pregnant or lactating women and patients with high rates of cell turnover, such as those with hemolytic anemia, may require 500 to 600 micrograms or more per day.
And for preventing neural tube defects, that's a well-known connection.
Yes, for the prevention of neural tube defects, a daily intake of at least 400 micrograms of folate from food or supplements, beginning a month before pregnancy and continuing through at least the first trimester, is recommended. For women with a history of a pregnancy complicated by a neural tube defect, an even larger dose of 4 milligrams per day is recommended. Folate supplementation is also being considered for patients with elevated levels of plasma homocysteine.
How is folate absorbed and distributed, and what are common causes of deficiency? Is it also absorption issues?
Folates in food are largely complex forms and need to be broken down before absorption in the small intestine, primarily in the upper part. Because most absorption occurs in the proximal small intestine, it's not unusual for folate deficiency to occur if that part of the intestine is diseased. Once absorbed, folate is rapidly transported to tissues as methyltetrahydrofolate. A constant supply is maintained by food and by an enterohepatic cycle of the vitamin, where the liver processes and recirculates folate through bile. The importance of this enterohepatic cycle is highlighted by studies showing a rapid reduction of plasma folate after bile drainage or alcohol ingestion, as alcohol apparently blocks the release of methyltetrahydrofolate from hepatic cells.
So alcohol is a common culprit for folate deficiency, interfering with that recycling.
Yes, folate deficiency is a common complication of small intestinal diseases that interfere with absorption and the enterohepatic cycle. Its prevalence in persons over 65 is relatively high due to reduced dietary intake or intestinal malabsorption. In acute or chronic alcoholism, severely restricted dietary intake of folate and impairment of the enterohepatic cycle by alcohol's toxic effects make it the most common cause of folate-deficient megaloblastic erythropoiesis, and also the most amenable to therapy, often simply by reinstituting a normal diet.
Makes sense.
Disease states with a high rate of cell turnover, such as hemolytic anemias, can also be complicated by folate deficiency. Additionally, drugs that inhibit folate enzymes or interfere with absorption can lower plasma folate and cause megaloblastic anemia.
How does folate deficiency clinically present? Is it just the anemia?
Folate deficiency is recognized by its impact on the hematopoietic system, reflecting its increased requirement with high rates of cell turnover. The megaloblastic anemia that results from folate deficiency cannot be distinguished from that caused by vitamin B12 deficiency. However, in stark contrast to vitamin B12 deficiency, folate deficiency is rarely, if ever, associated with neurological abnormalities.
That's the key difference again.
Exactly. After deprivation of folate, megaloblastic anemia develops much more rapidly than after interruption of vitamin B12 absorption, typically appearing within 1 to 4 weeks, depending on an individual's dietary habits and stores. This rapid onset reflects the body's more limited stores of folate compared to B12.
Are there broader health implications of folate deficiency beyond anemia, like homocysteine?
Absolutely. Folate deficiency is implicated in the incidence of neural tube defects, a serious concern during pregnancy. An inadequate intake of folate can also result in elevations in plasma homocysteine. This is a significant concern because even moderate hyperhomocysteinemia is considered an independent risk factor for coronary artery and peripheral vascular disease and for venous thrombosis.
Wow, a cardiovascular risk factor.
Yes, this highlights folate's crucial role as a methyl donor in the homocysteine to methionine conversion, a pathway that impacts cardiovascular health.
What are the general principles for treating folate deficiency?
The therapeutic use of folic acid is primarily limited to the prevention and treatment of deficiencies. As with vitamin B12 therapy, effective use depends on accurate diagnosis and understanding the mechanisms at play. Dietary supplementation is necessary when a normal diet might not meet requirements. For instance, daily ingestion of a multivitamin with 400 to 500 micrograms of folic acid is standard practice before and during pregnancy to reduce neural tube defects and during breastfeeding. For women with a history of a neural tube defect complicated pregnancy, an even larger dose of 4 milligrams per day is recommended.
Okay.
Patients on total parenteral nutrition also need folic acid supplements due to limited liver folate stores. Adults with high cell turnover conditions like hemolytic anemia generally require 1 milligram of oral folic acid once or twice daily, and the 1 milligram dose is also used for patients with elevated homocysteine.
And always investigate the underlying cause, right? Don't just treat the symptom.
Always. Any patient with folate deficiency and megaloblastic anemia should be carefully evaluated to determine the underlying cause, including assessing medications, alcohol intake, travel history, and gastrointestinal tract function. Therapy should always be as specific as possible, and multivitamin preparation should be avoided unless there's a strong reason to suspect multiple vitamin deficiencies.
And that critical caveat about B12 versus folate one last time because it's so important.
This is perhaps the most important point in this entire discussion. The potential danger of mistreating a patient who has vitamin B12 deficiency with folic acid alone must be kept in mind. Administration of large doses of folic acid can result in an apparent improvement of the megaloblastic anemia because it circumvents the methylfolate trap. However, folate therapy does not prevent or alleviate the neurological defects of vitamin B12 deficiency, and these neurological issues may progress and become irreversible. This distinction is vital for accurate diagnosis and treatment.
What therapeutic forms of folate are available? Is it just folic acid pills?
Folic acid is marketed as oral tablets containing tyrrolglutanic acid or L-methylfolate and as an aqueous solution for injection. Folinic acid, also known as leucovorin calcium, is another form. Its principal therapeutic uses are as a rescue agent after high-dose methotrexate therapy to counteract the drug's effects and replenish active folate stores, and to potentiate fluorosil in colorectal cancer treatment. It's also used as an antidote to counter the toxicity of other folate antagonists.
So it has specific uses, especially in cancer therapy.
Right. However, folinic acid generally provides no advantage over standard folic acid for treating deficiency, is more expensive, and therefore is not recommended, with the single exception of megaloblastic anemia associated with a rare congenital enzyme deficiency.
How do we monitor folate levels to ensure proper treatment and diagnosis? And how do we tell it apart from B12 deficiency in the lab?
Evaluation of the serum folate level can help exclude folate deficiency if it's above 5.0 nanograms per milliliter. Red cell folate levels reflect chronic folate levels and are less affected by acute ingestion than serum levels, but they are more time-consuming and costly to measure. Serum folate concentrations often correlate with serum homocysteine, which is a sensitive marker of deficiency. Critically, if a patient has a low serum or red cell folate level, follow-up tests should include both serum homocysteine and serum methylmalonic acid. Serum homocysteine is elevated in both B12 and folate deficiency, but serum methylmalonic acid is elevated only in B12 deficiency. This distinction is vital for accurate diagnosis and ensuring the correct treatment.
Homocysteine for both, methylmalonic acid only for B12.
Got it.
And any untoward effects for folate, is it generally safe?
There have been rare reports of reactions to injected folic acid. Oral folic acid is usually not toxic. However, large amounts of folic acid may counteract the anti-epileptic effect of certain medications and can increase the frequency of seizures in susceptible children. The FDA recommends that oral tablets of folic acid be limited to strengths of 1 milligram or less.
What an incredible journey we've taken today. We've journeyed deep into the astonishing world of hematopoiesis, from the tireless work of stem cells in your marrow to the complex signals of growth factors like EPO, G-CSF, and the innovative TRAs, and finally to the fundamental building blocks provided by iron, B12, and folate. We've reinforced how each component is indispensable for a healthy blood system.
It's truly a complex biological factory working silently within you, adapting to incredible demands, from fighting a simple cold to recovering from major surgery. Understanding this system not only illuminates our body's incredible capabilities, but also deepens our appreciation for the science behind diagnosing and treating blood disorders.
As you reflect on this, consider how diseases that initially seem unrelated, like chronic kidney disease or certain cancers, can have profound impacts on blood production, highlighting the deep interconnectedness of our body's systems. Or how the delicate balance of a single mineral like iron or a vitamin like B12 can ripple through our entire physiology, from red blood cells to brain function.
What new therapeutic avenues might emerge as we gain even deeper insights into these intricate feedback loops and cellular interactions? This knowledge empowers you to understand the why behind many common health issues and treatments, and perhaps even to look at your next meal as more than just food, but as the raw materials for your body's next generation of essential cells.
A truly profound thought. Thank you for joining us on this deep dive.